The melanocytic disorders of the skin. Melanocytic disorders of the skin. This includes vitiligo. Vitiligo is characterized by acquired depigmentation resulting from autoimmune destruction of the melanocytes. Okay, so this is condition vitiligo. Okay, then there is acanthosis nigricans. Acanthosis nigricans, a pigmented skin lesion commonly present in the axillae that may be phenotypic marker of an underlying adenocarcinoma of the stomach. Okay, a pigmented skin lesion commonly present in the axillae that may be a phenotypic marker for an underlying adenocarcinoma of the stomach. Then there is freckles. Okay, freckles is a pigmented macular lesion that occur in sun exposed area of the skin. They are not pre-malignant and have normal number of melanocyte along the basal cell layer but increased melanin. Okay, the number of melanocytes are normal but the melanin is increased within the individual melanocyte. Then there is Lentigo Simplex. It is similar to the freckle, okay, except there are increased number of melanocyte. There are increased number of melanocyte, but there are in the freckles there are number of normal melanocytes. But in Lentigo Simplex, the number of melanocyte is increased along the basal layer. Also, there is increase in melanin in each melanocyte. Then there is another condition known as Nevus. Nevus is a congenital lesion of the skin which has the Nevus cell. The Nevus cells are similar to melanocytes but different from melanocyte in being arranged in clusters or nests. Then there is melanocytic nevus. It is benign neoplastic proliferation of neural crest derived melanocytes. Then there is junctional navi. Junctional navi contain nests of pigmented nevus cells proliferating along epidermodermal junction. Okay, appear as flat pigmented lesion. The junctional navi. Junctional navi usually developed into compound navi as nevus cell extend into the underlying superficial dermis following columns of cells so that both junctional and intradermal component is present. Raised, pigmented and varicula like lesion. Intradermal nevus, which is the most common type of nevus in adults, located in the upper dermis. Then dysplastic nevi may be a part of dysplastic nevus syndrome and they may be precursor lesion of malignant melanoma. Malignant melanoma, it is a malignant tumor derived from melanocyte. Okay, both sexes are affected equally, male and female. It is more common in whites than in African Americans and has a predilection for fair skinned people. Exposure to excessive sunlight at an early age is the single most important predisposing risk factor. Other risk factors include a history of severe sunburn, dysplastic nevus syndrome, melanoma in first or second degree relative, and xeroderma pigmentosum. Okay, about 10 to 15% melanomas have genetic abnormalities. Most common aberrations are mutations in CDKN2A, RBPTEN genes, activating mutation in NRAS, BRAF are also implicated. Symptoms such as bleeding, itching, ulceration, pain in pigmented lesion warrant evaluation. The following signs are indicative of development of malignancy in pre-existing lesion. Asymmetry. One half of the lesion does not match the other half. Border irregularity. The edges are raised and the nose or blood. Color variation. Pigmentation is not uniform, may display shades of tan, brown, or black, white, reddish, or blue. Discoloration is of particular concern. Diameter. A diameter greater than 6 millimeter is characteristic. Although some melanomas may have smaller diameters, any growth in nevus warrants an evaluation. Evolving. Changes in the lesion over time are characteristic. This factor is critical for nodular or non-pigmented melanoma, which may not exhibit the classical criteria. Most variants have an initial radial growth phase in which malignant melanocyte proliferate laterally within the dermis, along the dermo-epidermal junction or within the papillary dermis. Metastasis cannot occur in this phase. There may be vertical growth phase in which malignant cells penetrate the underlying reticular dermis. Metastasis can occur in this phase. Tumor cells are polygonal to spindle, larger than normal. Melanocyte have atypical nuclei showing irregular contour and prominent eosinophilic nucleoli. Intracytoplasmic melanin is usually seen tumors not for showing pigment called amelanotic melanomas. Various patterns of growth of tumor cells may be seen, including solid sheets, silent glands. The superficial spreading melanoma is most common type. Superficial spreading melanoma primarily affect women over 50 years of age. The lower extremities and back are the most common location. Histologically, the phagocyte infiltration of the epidermis by atypical melanocyte. Lentigo melanoma is an extension of lentigo maligna. The intraepidermal lesion primarily occur on the sun-exposed face of an elderly person and histologically characterized by predominantly junctional proliferation of melanocyte and extension along adnexal structures. Solar elastosis is typically present. Nodular melanomas lack a radial growth phase and directly invade the dermis. Acral lentiginous melanomas are located in the palm soles or sublingual regions and usually affect African Americans. The Breslow system of staging measures of depth of invasion from the outermost granular layer to the deepest margin of the tumor lesion with the 0.76 millimeter of invasion usually do not metastasize, whereas those 1.7 millimeter of invasion have the potential for lymph node metastasis. The Clark system subdivides invasion into levels 1 through 5. Common cystic disorders of skin: epidermal inclusion cyst, pillar cyst. It is derived from the epidermis of hair follicle, the epidermal inclusion cyst, and contains laminated keratin material. Pillar, the sebaceous cyst, most commonly located on the scalp. It is similar to the epidermal inclusion cyst except for the absence of a stratum granulosum layer in the cyst wall and absence of laminated keratin within the cyst.